Thank you very much to the Society for the invitation.
Okay, so we heard that weight loss
is nothing good in cancer patients and in many other chronic diseases. The onset of weight loss in cancer may be before or upon diagnosis, during the course of the disease, and after medical and surgical treatment. We heard that weight loss is a predictor of survival, and this was quite clearly shown by Lisa Martin in this study, which was already presented. And what about patients at first medical oncology visit? We have another confirmation that weight loss is there. Actually, 65 of cancer patients upon first medical oncology visit, as demonstrated by the Premium study we ran in Italy on some 2,000 patients, shows that 65% of cancer patients upon first medical oncology visit already experience weight loss. And of course, the entity of weight loss may be different according to the type of the tumor and also the stage of the tumor, being more pronounced in patients with more advanced and metastatic cancer. You see here also that patients at first medical oncology visit display a high prevalence of malnutrition as measured by MNA, and that the prevalence of malnutrition is depending upon being or not metastatic and depending very dramatically by the type of tumor, with the minimal impact, for example, on nutritional status in breast cancer and maximal impact in gastroesophageal, pancreas, head and neck, and respiratory tract cancer. Also, the study shows that according to the classification of Fearon et al., the prevalence of cachexia at first medical oncology visit, which means before starting any kind of chemotherapy or radiotherapy, is also elevated. And again, it's higher in patients with GI tract tumors and with metastatic cancers. We know that cachexia kills people, and it is 20 to 25% of patients who are killed by the negative consequences, either direct or indirect consequences of cachexia. We also know that the most clinically relevant phenotypic feature of cachexia is muscle loss, which impact on several physical function and also reduce tolerance to treatments. Now, when we talk about sarcopenia, we actually allude to different conditions. What happens is that recently, when we talk about sarcopenia, we may refer to the syndrome of progressive weight loss and muscle loss of aging, the loss of muscle mass and function of different diseases, and the reduction of skeletal muscle mass as derived by CT scans, which is often used as a synonymous of sarcopenia in cancer patients, although this is assessing only mass, not really function. But this is good. And thank you, Vicky, for giving me this slide, even if you don't know. Thank you. And we know that sarcopenia, as measured by CT scan, is negatively impacting on dose-limiting toxicity. Those patients with reduced muscle mass do experience higher risk of developing dose-limiting toxicity, and many of these patients may be told, we are sorry, we have to stop or reduce the intensity of chemotherapy because of the side effects. So there is quite a good number of reasons to suggest that we should seriously take into consideration nutritional issues in cancer patients. And this is the concept behind the philosophy of the parallel pathway we have devised some years ago, just to support the concept that we should create a pathway which runs parallel to the very well structured oncological diagnostic and therapeutic pathway. And within this metabolic and nutritional pathway, we should offer the patient whatever he or she needs throughout the cancer journey. But the very important thing, which is And this concept is very much supported by the evidence of a previous study. This pathway should start at the moment the diagnosis of cancer is performed, and not at the moment the diagnosis of malnutrition or even cachexia is performed. So maybe in this phase, some patients do not need active support, while others may need, as the Premio study suggests. These are the components of the parallel pathway. Of course, there is a number of medical actions which should be implemented, but overall, we have to elaborate a nutritional plan and planning nutritional and metabolic follow-up. And of course, considering the multifactorial pathogenesis of weight loss and cachexia of cancer, we, of course, suggest that this should be a multimodal approach with early intervention, nutritional support, and many other tools we may have available, including pharmacological treatment, which, of course, would be welcome for the treatment of cancer cachexia. Now, it's quite interesting to observe that we have initial data coming from a parallel pathway-like approach to cancer patients, and this is what Elisabeth de Wel in Belgium is now doing on a larger scale. These are the results of a clinical study where it is demonstrated that the tight caloric control for cancer patients, offering them normal feeding or supplemented oral feeding, enteral nutrition and parenteral nutrition on demand. This means when they needed all this in order to cover the energy and protein needs is associated with less hospitalization. And look at here, this is quite amazing, a big difference in mortality. So the question is, why should nutritional metabolic care be considered part of good clinical practice in oncology? Well, there are good reasons to suggest this, and the reasons are listed here, and basically they summarize what we have been talking until now. But then the question arises whether neglecting nutritional metabolic issues in cancer patients can be considered, in a way, malpractice. Well, cancer guidelines refer to nutritional intervention or monitoring in different conditions. For example, for cancer-related fatigue, there is a strong recommendation for nutrition consultation and optimized nutritional treatment, and also in palliative care oncology, there is a strong reference to nutrition. Now, let's take a look at this interesting article, which was written by an oncologist for oncologists, oncologists and medical malpractice. This is the list of areas of litigation in oncology practice. So what may bring oncologists to the court because of malpractice claims? Delay in diagnosis of cancer, chemotherapy dosing, pain control, informed consents, protection of privacy, and genetic counseling. And I think chemotherapy dosing has much to do with our reasoning. Let's take a look at what she says. Every day we write multiple orders for complicated regimens involving several calculations, body surface area, creatinine clearance, area under the curve, consideration of organ function and patient age, renal function with cisplatin, heart disease with anthracyclines, previous drug exposure, cumulative anthracycline, embryomycin doses, heavy pretreatment, toxicities, prior taxane neuropathy, and so on. So she says a potential Achilles heel for oncologists then would be errors in chemotherapy prescribing. So, based on what we know, we can conclude that weight loss is highly prevalent in cancer patients, even at first medical oncology visit, and independently predicts mortality risk. Loss of muscle mass and function is is the most clinically relevant feature of cancer-related weight loss and cachexia. Sarcopenia in cancer patients may increase the risk of chemotherapy toxicity and chemotherapy-related adverse events. And last but not least, based on the currently available evidences, the risk that neglecting nutritional issues in cancer patients might generate in the future malpractice claims and subsequent malpractice suits should be considered. Thank you.